Crisis. Collapse. Is the system failing us? Who do we trust now?
So if you've ever driven through a truly rural area late at night, you know exactly how dark it can get.
Oh, yeah. Pitch black.
Right. I mean, you're a mile from the nearest interstate. The trees are just like crowding the shoulder of the road. The pavement is uneven, and there are absolutely no streetlights out there.
None at all.
It's the kind of dark that honestly feels heavy. But then, you come around a bend in the road, and there it is.
The hospital.
Exactly. Sitting on a low hill, just glowing against the night sky like a lighthouse. A rural hospital.
It's a really striking image. And for the people who actually live in those areas, it's an incredibly comforting one.
Yeah, definitely.
Because in that deep darkness, that glowing building represents, well, a fundamental baseline of safety. It's a promise, really.
A promise that they're not totally on their own.
Right. A promise that no matter what happens out there in the dark, like a bad car accident or a kid waking up with a sudden spiking fever or premature labor, there's a place ready to catch you. You know the lights are always on.
It's this reliable beacon. You don't even really think about it on a daily basis if you live there. You just know it's there. But what happens when the power source for that lighthouse gets fundamentally rewired?
That is the big question.
Because in July 2025, a single piece of legislation did exactly that. It completely altered the current that keeps those lights on.
Yeah, it really did.
So today on this deep dive, we are looking at the Working Families Tax Cuts Act, which was signed into law by President Trump on July 4th, 2025.
And supporters affectionately dubbed it the One Big Beautiful Bill.
Right, the One Big Beautiful Bill. And today we are going to look past all the political rhetoric of that signing day. We want to map out exactly how federal tax and budget strategies physically reshape the landscape of healthcare access in rural America.
And to do this, we are synthesizing a few key sources today. We've got the legislative breakdowns of the bill itself, focusing specifically on
Crisis.
Estimated $1
Collapse.
trillion
Is the
in
system
Medicaid.
failing us?
Which is
Who do
just a
we
massive
trust
number.
now?
Huge. And we also have current on-the-ground data regarding the rural hospital closure crisis.
Right.
And to kind of anchor all of these massive abstract numbers, we have this really poignant narrative case study. It's titled The Fading Lighthouse of Breyer County.
That's where we got the lighthouse analogy.
Exactly. And it tracks the human cost of these policies year by year from 2026 all the way out to 2031.
So for you listening right now, whether you live in a rural county where, everybody knows the local doctor, or you live in a bustling city where you can literally walk to 3 different urgent care clinics in 10 minutes, understanding this dynamic is crucial.
Because healthcare isn't just about medicine.
Exactly. It is the economic bedrock of communities. So we're going to get into the macro policy, the brutal math of hospital funding, and, well, the real human stories of what happens when a community safety net is systematically dismantled.
It's a lot to cover.
It is. So before we look at the hospitals actually turning off their lights, we have to look at the legislative spark. Because I was reading through the background of this bill, and the legislative mechanism they used to pass it immediately stood out to me.
The budget reconciliation process.
Right. This wasn't like debated and passed like a standard run-of-the-mill healthcare bill, was it?
No, not at all. The Working Families Tax Cuts Act, or H.R. 1, bypassed the normal route entirely. It was passed via budget reconciliation.
Now, I hear that term thrown around Washington a lot on the news, but how does that actually change the DNA of the bill? Like, why does it matter that they used budget reconciliation instead of just introducing it normally?
Well, it matters immensely because it dictates the entire structural strategy of legislation. Budget reconciliation is this special legislative process created back in the 1970s.
Okay.
It was originally designed just to make it easier for Congress to pass bills that adjust federal spending and revenue, to keep things aligned with the annual budget resolution.
Just housekeeping stuff, originally.
Exactly. But the most critical feature of reconciliation, and the reason it is so intensely coveted by whichever party holds power, is that it only requires a simple majority in the Senate to pass.
It completely bypasses the 60-vote filibuster rule.
Precisely.
Yeah.
So if you have a narrow majority, this is your fast-track vehicle. You literally don't need a single vote from the opposing party.
Wow. Okay, but there's a catch, right? I mean, you can't just cram anything you want into a reconciliation bill, can you?
No, you can't. You are heavily constrained by something called the Byrd Rule. named after former Senator Robert Byrd.
Right, the Byrd rule.
The Byrd rule essentially states that every single provision in a reconciliation bill must have a direct, substantial impact on the federal budget.
So no ideological pet projects.
Exactly. You can't use it to pass like purely social legislation or broad regulatory changes.
Yeah.
It has to be about dollars and cents, taxes, spending, and the deficit.
Okay, that makes sense.
And furthermore, a reconciliation bill cannot increase the federal deficit beyond the specific window set by the budget resolution, which is typically 10 years.
Ah, so there's the math problem.
Right. Because if you're going to pass massive, sweeping tax cuts, which this bill absolutely does, heavily reducing both individual and corporate tax rates, those tax cuts are going to reduce government revenue by trillions of dollars.
And because of the Byrd rule, you can't just add those trillions of dollars to the national credit card without any limit.
You can't.
You have to balance the ledger at least within the parameters of those reconciliation rules, which means, logically, you need to be in an enormous pile of money to cut.
Precisely. And that brings us to the core dynamic of this entire piece of legislation. To make the math work on these massive tax cuts, the bill includes major structural spending reductions.
And the target was healthcare.
Right. The primary vehicle for those reductions is a massive restructuring of healthcare, specifically Medicaid and certain subsidies tied to the Affordable Care Act.
Okay, wait, I want to make sure I'm fully grasping the intent here. Are you saying that the architects of this bill looked at healthcare and essentially said, hey, we need a piggy bank to pay for these corporate tax cuts. Let's go raid Medicaid. Well, because the way you describe it, it sounds like healthcare wasn't even the actual focus, but just a convenient funding mechanism.
So if we look at this completely impartially, relying strictly on the stated arguments of the lawmakers who drafted it, they would strongly push back on the idea that they simply raided Medicaid.
Okay, how do they frame it?
They frame this as a philosophical dual victory. They argue that they're actually tackling two distinct problems simultaneously.
Two birds with one stone.
Exactly. On one hand, they fundamentally believe that cutting taxes is the absolute best way to stimulate the broader economy, spur business investment, and can put money back into the pockets of Americans.
Standard supply-side economics.
Right, right. But on the other hand, they have long argued that the Medicaid system itself, especially after it expanded under the Affordable Care Act, had just grown far too large.
They see it as bloated.
Very much so. They view it as an inefficient entitlement program that is fundamentally unsustainable in the long run. So they view the Medicaid cuts not just as a way to balance the spreadsheet, but as a deeply necessary right-sizing of federal spending.
So in their view, the system needed to be shrunk regardless of the tax cuts.
Yes. Supporters argue that these reductions force efficiency. They eliminate waste and scale back a program that they feel, frankly, had overstepped its original mandate.
Which was just protecting the absolute most vulnerable.
Exactly. So in their view, reforming this overgrown system is good policy on its own merits. And hey, it conveniently also provides the capital necessary to fund the tax relief.
Right. It's a fundamental shift in the philosophy of federal spending. But regardless of the political philosophy behind it, the mechanical reality on the ground is that when you pull $1 trillion out of a healthcare system, the actual need for that healthcare doesn't just evaporate.
No, it certainly does not.
Like, if the federal government decides it is no longer paying for something, the medical realities of the population don't suddenly cure themselves. People are still going to develop chronic conditions.
People still get injured in farming accidents.
Exactly. Pregnant women still go into labor. So if the federal funding vanishes, where does the burden go?
It shifts downward. It just cascades right through the system.
How so?
When federal healthcare spending is reduced on a macro level, that burden shifts first to the state governments. State Medicaid systems suddenly find themselves having to do significantly more, but with far less federal matching money.
And I'm guessing the states pass that burden along too.
They do. From the state level, the burden shifts all the way down to the local level. It lands squarely on the doorsteps of local access points.
The hospitals.
The safety net hospitals, the rural clinics, and ultimately the local communities and taxpayers who are suddenly left trying to figure out how to care for a massive surge of unfunded patients.
Which brings us to the actual math of it all. I want to transition from the macro policy in Washington down to the exact levers they pulled. Because $1 trillion is a massive, almost incomprehensible number.
It really is hard to visualize.
It is. Like, if I asked you to cut $1 trillion from my budget, where do you even start? Where exactly does $1 trillion go? Or, I guess, more accurately, where does it stop going?
Well, according to the legislative analyses in our sources, the total reduction to healthcare spending is estimated to be somewhere between $900 billion and $1.2 trillion over a decade.
Just a staggering amount of money.
It is. And it's crucial to understand that lawmakers didn't just, cross out Medicaid budget with a red pen and write a smaller number next to it.
Right, it's not just one line item.
Not at all. It's a stack of really specific, complex policy changes that compound on top of one another to extract that money from the system.
Okay, so what is the biggest lever they pulled? If you're building a stack of cuts that reaches $1 trillion, what's the foundation of that stack?
The single most significant driver of these savings is the implementation of strict new work requirements.
Work requirements, okay.
The bill mandates that starting in 2027, able-bodied adults who are enrolled in Medicaid must prove that they are engaged in 80 hours a month of work, job training, or community volunteering in order to maintain their health coverage.
80 hours a month. So that breaks down to roughly, 20 hours a week?
Roughly, yes.
I think if you just hear that on a quick news broadcast, a lot of people might nod their heads and say, well, that sounds entirely reasonable. Just get a part-time job or do some volunteering to keep your government health benefits.
It sounds like a basic expectation of productivity, sure.
Right. But looking at the sources, the reality of how these requirements actually play out in the real world is vastly different from the theory on a whiteboard in Washington.
It is vastly different. And honestly, it raises an incredibly important point about how bureaucratic systems actually function or fail to function for vulnerable populations.
Right, because the data tells a very different story.
Exactly. The data from this bill, along with past case studies on smaller scale Medicaid work requirements, show us a really consistent pattern. When people lose their health care coverage due to these requirements, it is very, very rarely because of an outright stubborn refusal to work.
Right, because the narrative we so often hear is, someone sitting on their couch looking at a job application and just saying, nah, no thanks, I'd rather just keep my full health care.
But that's simply not what the data reflects.
So what actually happens?
The primary mechanism of coverage loss isn't a lack of willingness to work. It is the friction of the bureaucratic system itself.
The friction?
Yes. You have to consider the reality of the low-wage labor market, especially in rural America. These are not salaried office jobs with predictable 9-to-5 schedules.
No, they're shift work.
Exactly. Hours fluctuate wildly. A person might work 35 hours one week because the local diner is busy, right? But then their shifts are cut to maybe 12 hours the next week because business is slow.
And that's entirely out of their control.
Completely. And then you have people relying on cash jobs, agricultural day labor, landscaping, domestic work, which don't provide standard pay stubs or W-2s to easily prove employment.
Oh, man. So proving you worked is just as hard as the work itself?
Exactly. And furthermore, you have a massive population of unpaid family caregivers looking after elderly parents or disabled children. And that often isn't recognized as work under the strictest definitions of these government programs.
So the nature of the work itself is volatile and hard to document. And then you add the actual reporting mechanism on top of it.
That's where it really breaks down.
Because I'm imagining how you actually prove this to the government. You don't just call up your governor on the phone and say, hey, I worked my 20 hours this week. We're good.
No, you definitely don't. You have to interface with a state-run administrative system. You have to log into a state portal, usually online.
Right.
You have to navigate these complex digital forms, upload specific documentation, and verify your hours every single month without fail.
Every single month. Okay, now picture doing that if you live in a rural county with spotty or completely non-existent broadband internet.
Which is very common.
Picture doing that if you don't even own a laptop and you have to rely on a cheap smartphone with a limited data plan.
Or consider the fact that state government websites are notoriously prone to glitches, crashes, and maintenance outages.
Oh, we've all been there with DMV websites. It's a nightmare.
Right. So if you miss your reporting window because the website wouldn't load your document, or simply because you misunderstood a complexly worded legal notice in the mail, the algorithm simply drops your coverage. You're out.
Wow. So I was thinking about this when I was reading the source, and it sounds less like a workforce incentive and more like setting up a labyrinth.
A labyrinth, yeah.
Like you set up a labyrinth for people to navigate just to get their health care. And the monster in the maze isn't some deep-seated laziness. The monster is a missing verification form. It's a temporarily dropped Wi-Fi connection. It's a shift manager who forgot to sign your timesheet on a Friday. It's just the sheer weight of the bureaucracy acting as a filter to knock people off the rolls.
The labyrinth is exactly what it is.
Yeah.
And, that friction is a feature of the policy's math, whether it was
Yeah.
intentional or not.
Because it saves money either way.
Precisely. The Congressional Budget Office and independent health economists estimate that this labyrinth alone will result in millions of people losing their insurance. The federal government saves hundreds of billions of dollars simply by shedding enrollees who just get lost in the paperwork.
That is just staggering. But as I read further into the sources, there's another massive chunk of these cuts that almost nobody outside of hardcore health policy circles ever talks about.
The provider tax caps.
Yes. It's a mechanism called provider tax caps, and the sources estimate it accounts for around $375 billion in savings.
It's a huge piece of the puzzle.
And I have to admit, when I read the phrase provider tax cap, my eyes immediately glazed over.
I don't blame you.
It sounds like the most boring, dry accounting term imaginable. How on earth does capping a tax save the government $375 billion?
It is incredibly dense accounting, I'll give you that. But it is one of the most vital funding engines for hospitals in the entire country, so we really need to break down exactly how it works.
Okay, let's do it.
Historically, state governments have used a very specific and highly complex financial maneuver to maximize the amount of money they get from the federal government for their Medicaid programs.
Okay, walk me through this maneuver step by step. Let's pretend we are running a state.
All right, let's say you are running state X. You want to increase how much you pay your hospitals for Medicaid patients, right? But your state budget is tight. You just don't have the cash on hand.
Fair enough.
Now, the federal government matches your state Medicaid spending. In a standard scenario, if your state spends $1 on Medicaid, the federal government might give you $1 or more in matching funds, depending on your state's specific formula.
Okay, so I spend $1, Washington sends me $1. Got it.
Exactly. So, State X comes up with a plan to maximize this. The state levies a specific tax on its own healthcare providers. Let's say it taxes all the hospitals in the state.
Hold on, wait. The state taxes the hospital, the actual institution that is supposed to be providing the care.
Yes. The hospitals pay this newly created tax directly to the state treasury.
Okay.
The state then takes all of that new tax revenue and deposits it directly into its Medicaid budget.
Okay, I see where this is going.
Right. Now, the state goes to the federal government and says, hey, look, our Medicaid budget just went up significantly. We're spending all this new money.
Even though it's just the hospital's own money.
Exactly.
Yeah.
But because the federal match is a percentage of what the state spends on paper, this artificially inflated state budget triggers a massive infusion of new federal cash. The federal government sends a huge check to state X based on that higher total.
Okay, I'm following the money. The state taxes the hospital, uses that tax money to artificially inflate its budget on paper, which triggers a massive payout from the feds.
You've got it.
But wait, what happens to the hospitals? They just paid a huge tax. They're out of pocket.
And this is the final crucial step of the maneuver. The state takes that massive new federal payout, turns around, and gives it back to the hospitals in the form of significantly higher Medicaid reimbursement rates or supplemental payments.
Are you serious?
Dead serious.
So the state taxes the hospital, uses that exact same money to leverage federal dollars, and then hands the profit back to the hospital.
Yes.
That sounds less like a legitimate tax and more like a massive financial loophole to just siphon money out of Washington.
Well, you hit the nail on the head, because proponents of the One Big Beautiful Bill viewed this exact mechanism as a massive, deeply exploitative loophole.
I can see why.
They saw states artificially inflating their spending just to draw down billions in federal funds that they shouldn't have realistically been entitled to.
Right.
Which is exactly why the legislation placed strict caps and limits on how states can use these provider taxes to secure federal matching funds. They essentially closed the loophole. By capping this mechanism, the federal government stops paying out those inflated matches, saving an estimated $375 billion over the decade.
I mean, logically, I understand why lawmakers would want to close a loophole like that. It makes sense on paper. But what is the actual consequence on the ground? Because if that loophole was generating billions of dollars and that money was flowing back to the hospitals...
The consequence is an immediate, catastrophic drop in hospital revenue.
Because the supplemental payments stop.
Exactly. That $375 billion was previously flowing directly into the operating budgets of hospitals. And the hospitals that relied on those supplemental payments the absolute most were the safety net and rural hospitals that treat really high volumes of Medicaid patients.
Wow. So you have the work requirements creating this administrative labyrinth that knocks millions of people off the insurance rolls, taking away their ability to pay for care.
Right.
And simultaneously, you have these provider tax caps quietly draining hundreds of billions of dollars directly from the hospital's operating budgets.
It's a two-front assault on their revenue.
What else is in this stack of cuts? Is there more?
There is. The bill also includes stricter eligibility verifications, requiring states to much more aggressively check income and residency statuses, which further trims the enrollment numbers.
More paperwork friction.
Exactly. There are also new limits placed on certain non-citizen eligibility. And additionally, the bill allows certain subsidies tied to the Affordable Care Act, Obamacare, to expire or be significantly reduced.
Oh, wow. What does that do to the broader market? Like, if ACA subsidies shrink, how does that compound the Medicaid issue we were just talking about?
It creates this really painful spillover effect. When those subsidies are reduced, the out-of-pocket premiums for insurance plans on the individual market rise sharply.
Because the government isn't subsidizing the premium anymore.
Right. So people who are hovering just above the poverty line, who previously relied on those subsidies to afford a private ACA plan, suddenly find themselves totally priced out.
So they have to drop their coverage.
They do. And if they can't navigate the newly restrictive, labyrinthine Medicaid system we just discussed, they have nowhere left to go. They fall straight into the ranks of the uninsured.
When you add all of these levers together, the work requirements, the provider tax caps, the strict verifications, the expiring subsidies, what is the final human tally? Like, what does the math actually translate to in terms of human lives?
The estimates synthesized across our sources indicate that this combination of policies will result in 10 million or more additional people becoming uninsured over the next decade.
10 million more people.
Yes.
10 million more people who, when they discover a lump or suffer a severe laceration or experience chest pains will have absolutely no financial means to pay for their care.
Exactly. 10 million people stripped of their purchasing power in the healthcare market entirely.
Which brings us directly to the doorstep of the hospitals themselves. We now understand how the cuts work mechanically. But looking at the sources, I want to understand the target.
Why rural hospitals specifically?
Yes. Why do these specific cuts hit rural hospitals so disproportionately hard? Why aren't massive urban hospitals in New York or Los Angeles facing the exact same existential threat?
To understand that, we have to look at the baseline reality of rural healthcare in America before this bill was ever even drafted.
Okay.
It was absolutely critical to note that the One Big Beautiful Bill did not create the rural hospital crisis out of thin air.
It was already bad.
It was. The bill simply poured high-octane gasoline on an already raging fire.
Let's look at those baseline numbers from the sources because they are staggering. Over 100 rural hospitals had already closed their doors permanently since 2005.
Right?
So this bleeding, this erosion, had already been happening for 2 decades prior to the legislation. And furthermore, the data shows that before the bill was even signed, roughly 700 to 800 rural hospitals were already classified as financially vulnerable or at immediate risk of closure.
Which is roughly 1/3 of all rural hospitals in the entire country. Yes. They were already operating right on the brink of insolvency. But post-bill, with these new Medicaid cuts and provider tax caps factored into their financial projections, the situation shifts from concerning to critical.
How critical?
A March 2026 report cited in our sources places over 400 hospitals at immediate high risk of closure or major service cuts within just months.
Months.
Yeah. That includes 176 rural facilities and 267 urban safety net facilities. And the geographic distribution is really stark. The regions being hit the absolute hardest are the South and the Midwest.
Places like Texas, Georgia,
Alabama, Kentucky, states which already had higher proportions of vulnerable, low-income populations.
Okay, so here is the question that I think a lot of people, especially those with a business background, would immediately ask. I'm going to ask what might sound like a terribly naive business question.
Go for it.
If a hospital is losing money, why can't it just run leaner?
The classic question.
Seriously, think about it. If a restaurant is having a slow quarter, they adapt, right? They cut back on staff hours, they order less inventory, they close during the slowest hours of the day.
Maybe turn off the AC in the back.
Exactly. They reduce their overhead to match their revenue. Why can't a struggling rural hospital just tighten its belt, cut its overhead, and operate like any other struggling business until times get better?
That is the million-dollar question, and answering it really strikes at the absolute core of healthcare economics.
Mm.
The fundamental truth is that a hospital is not a retail store. It is not a restaurant.
Right.
The core problem for rural hospitals, the reason they cannot simply tighten their belts, is the rigid, inescapable ratio between their fixed costs and their patient volume.
Unpack that relationship for us. Fixed costs versus volume. How does that break the business model?
Well, a fixed cost is an expense that a business must pay, regardless of how many customers walk through the door, right?
Right, like rent.
Exactly. Now, if you are running a hospital, the defining feature of your facility is the 24/7 emergency room. By law, under the Emergency Medical Treatment and Labor Act, EMTALA, and by basic medical necessity, if you call yourself a hospital, you must maintain complete emergency readiness at all times.
Complete readiness.
Meaning
Yeah.
that at 3-4 a.m. on a quiet Tuesday night, you must have a physician on duty. You must have highly trained trauma nurses in the building. You need an anesthesiologist either in the hospital or immediately on call.
Even if the waiting room is totally empty.
Even if it's empty. Your expensive diagnostic equipment, the MRI machines, the CT scanners, the X-ray machines, they have to be powered, maintained, and staffed by certified technicians who are awake and ready to go.
Wow.
You have to keep the blood bank meticulously stocked, refrigerated, and monitored. You have to keep the backup generators fueled.
So you are paying for an incredibly high level of specialized labor and technical infrastructure every single second of the day.
Exactly. You must maintain that massive fixed cost, whether one single patient comes through the double doors all night or a multi-vehicle highway pileup brings in 30 critically injured patients all at once.
You cannot put a trauma center on standby to save on payroll.
You really can't.
Like, you can't tell a woman who shows up in active labor at midnight, hey, I'm so sorry, we actually sent the obstetrics team home to save on hourly wages. Can you hold off and come back when the day shift starts at 9 a.m.?
No, you absolutely cannot.
Yeah.
The overhead is astronomically high, and it is entirely non-negotiable. If you cut those fixed costs, you fundamentally cease to be a hospital. You just become a clinic.
Okay, I see.
Now let's contrast how those fixed costs are handled in an urban setting versus a rural setting. In a large, bustling urban hospital, those massive fixed costs of emergency readiness are spread out over hundreds or thousands of patients a day.
Right, high volume.
And crucially, a significant percentage of those urban patients have lucrative private commercial insurance provided by large employers.
Which pays better.
Much better. Private insurance reimburses the hospital at high rates, often generating a substantial profit margin on procedures and tests. So, the high volume of well-insured patients essentially subsidizes the staggering fixed costs of keeping the ER open for everyone else.
But in a rural hospital, the demographics completely flip the math.
Exactly. In a rural area, you are dealing with a much smaller population base, which means lower overall patient volume.
Less people to spread the cost over.
Right. Furthermore, the population tends to be older, sicker, and generally poorer than in urban centers. This means a much larger percentage of a rural hospital's patients are covered by Medicare for the elderly and Medicaid for low-income individuals.
And as we established, those don't pay as well.
Historically, Medicare and Medicaid reimburse hospitals at significantly lower rates than private commercial insurance. In many cases, the Medicaid reimbursement rate fails to even cover the actual baseline cost of providing the care.
Oh, so they lose money on those patients.
Exactly. So these rural hospitals were already operating on razor-thin or even negative margins. Nearly half of them were already losing money on patient services before 2025.
Just scraping by.
They were surviving purely on thin margins of scale, state subsidies, and federal funding mechanisms like the provider taxes we just discussed.
If I'm understanding the math here, it's a recipe for sudden collapse.
It is.
Because if a rural hospital is already operating right on the red line, relying entirely on Medicaid volume just to barely cover their massive, unchangeable fixed costs, and then the federal government passes a bill that slashes $1 trillion from Medicaid.
The math violently breaks.
It has to.
As the work requirements and eligibility restrictions from the legislation kick in, millions of people in these rural areas lose their Medicaid coverage. They become uninsured.
But they still get sick.
Exactly.
Yeah.
Remember the Emergency and Medical Treatment and Labor Act we mentioned earlier? When someone who has lost their Medicaid coverage has a heart attack or suffers a severe farming accident, they don't stay home. They still go to the local ER. And federal law strictly mandates that the hospital must treat and stabilize them, regardless of their insurance status or their ability to pay.
So the hospital is suddenly legally obligated to treat a massive surge of completely uninsured patients. They are providing the exact same expensive care, utilizing the exact same expensive equipment and staff, but they're receiving zero revenue for it.
Precisely. The volume of uncompensated care skyrockets. Their revenue plummets catastrophically, but their fixed costs, the doctors, the nurses, the electricity, the blood bank, they stay exactly the same.
The financial floor simply drops out from underneath them.
It does. It is a devastating collision between the rigid structural demands of emergency medicine and aggressive federal budget cuts.
And this isn't just like a theory drawn on a whiteboard in Washington. Our sources provide a really granular, incredibly affecting year-by-year look at exactly how this mathematical collision plays out in a real living community.
The Broward County case study.
Yes. I want to move from the national statistics and the legislative math down to the ground level. We need to see what these policies actually look like when they hit the pavement in a place where real people live and work.
It's vital to look at the human element.
So our narrative source is a case study titled The Fading Lighthouse of Broward County. It tracks Broward County Medical Center, which is located in a rural stretch of North Carolina.
And this narrative is so important because it illustrates the psychological and chronological timeline of a hospital closure.
Right, because it doesn't happen all at once.
No, when a community loses its hospital, it rarely happens overnight like a sudden earthquake. The doors don't just abruptly padlock shut on a random Tuesday. It is a slow, creeping, agonizing erosion of services.
Let's walk through that timeline. The source begins its focus in 2026, which is the year after the bill is signed into law. The authors call this period the quiet cuts.
The quiet cut.
I find that phrase so evocative because in Broward County in 2026, nobody genuinely believes the hospital is actually going to close. It's the lighthouse on the hill. It's a permanent fixture of their reality.
They always had it.
Right. There are no dramatic headlines in the local paper about bankruptcy. There are no protests. So if the hospital is still open and running, what is actually happening during these quiet cuts?
What is happening is deep administrative confusion that slowly chokes off access.
Oh, so?
In 2026, the state begins implementing the new, stricter eligibility verifications mandated by the bill. Patients in Broward County begin receiving thick, intimidating envelopes in the mail from the state health department.
The paperwork begins.
And the language inside these envelopes is dense, legalistic, and highly bureaucratic.
Yeah.
It says things like eligibility verification required under H.R. 1, or coverage pending documentation review, or action required to prevent termination of benefits.
And the source details the human reaction to these envelopes, which is incredibly telling about how policy actually lands on the public.
It really is.
Many people in Broward County simply didn't understand the forms. The legal jargon was impenetrable. Some people ignored them entirely, just assuming it was a mistake or junk mail because they had been on Medicaid for years without any issue.
Right. Why would it change now?
Exactly. And others tried earnestly to comply, but perhaps they missed a strict 14-day deadline, or they lacked a specific newly required piece of documentation, like an original birth certificate that they just couldn't easily locate.
And as a result of that confusion, they quietly slip off the insurance rolls. They're just dropped from the system.
Just like that.
The narrative notes that the administrative staff at the hospital sees the denial codes popping up in their billing software, but the physical reality is first noticed by the medical staff. Dr. Elena Ruiz, a physician in the Broward County ER, begins to observe a subtle but distinct shift in the patient population.
She notices that patients are arriving at the hospital later than they used to in the progression of their illnesses. They are visibly sicker. Their chronic conditions, like diabetes or hypertension, are far more advanced and less managed.
The narrative recounts a really specific instance where Dr. Ruiz treats a middle-aged man who comes into the ER with severe radiating chest pain.
Yeah, that story stuck with me.
Based on his presentation, he has clearly been experiencing symptoms for days. She asks him, frankly, why he didn't come in sooner when the pain first started.
And his response is just devastatingly simple. He says, I got a letter. I thought I didn't have insurance anymore. I was hoping it was just heartburn.
Hoping it was just heartburn.
He sat at home, enduring early signs of a cardiac event, delaying life-saving care, all because of a thick, confusing envelope he received in the mail. He was terrified of bankrupting his family with a hospital bill.
That is the very essence of the quiet cuts. The town doesn't see a budget spreadsheet. They don't see a chart showing provider tax caps.
They just see their neighbors getting sicker.
They see their neighbors delaying care, appearing sicker, while the hospital's billing department quietly notices that the stream of federal and state reimbursements is slowly, inexorably drying up.
And that quiet erosion sets the stage for the massive breaking point, because the timeline moves into 2027, and the source explicitly titles this year The Strain.
The strain. This is the massive inflection point for Broward County, because 2027 is the year that the 80-hour work requirements officially kick in.
Right. The labyrinth is fully constructed and activated.
Yes. And just as we discussed earlier, Broward County becomes the perfect, tragic case study for how these requirements fail in practice. The authors of the narrative explicitly point out the disconnect between Washington's assumptions and the county's reality.
Because they write that the economy of Broward County wasn't made of paper and predictable W-2s.
Not at all.
It was made of fluctuating hours at the lumberyard, cash jobs in seasonal agriculture, unreliable transmission on used cars making it hard to get to shifts across county lines.
And the unpaid family caregiving.
Right. So the bureaucratic friction hits the community like a tidal wave. The glitches in the newly updated state portal, the lost passwords, the inability to verify fluctuating hours within months. Hundreds of people in this single small county lose their Medicaid coverage entirely.
And this is exactly where the hospital's rigid math shatters.
Because the ER gets busier.
The ER suddenly gets much busier. The people who lost their coverage still get sick, they still get injured, and their unmanaged chronic conditions flare up into acute emergencies. They flood the ER, but the reimbursements plummet to near zero.